Good morning, clinical problem solvers. It's Tuesday. It's Neurology Virtual Morning Report, and we're excited to see everyone. Special welcome if there are any newly minted, newly matched future neurologists joining us for the first time or have been here and are now newly matched neurologists. Congratulations. We're excited to see everyone. If it's your first time here, we're going to discuss a neurology case over the next hour. So that'll require someone who'd like to present a case. If you have a case you saw in your practice, or if you're a student, resident, saw on the ward, we'll have you presented in little bits and then we'll discuss each part. So that could be a fun role you could play this morning. And then we'd love to have two learners to discuss that case with me. It's a low pressure, fun environment. If you haven't been here before, people can confirm. You'll take a shot at discussing what's been presented, and then I'll ask you some questions, discuss with you, all for learning and fun. And we usually like to ask that we have one discussant who identifies as a man and one who identifies as a woman. So do we have any volunteers to present a case and two volunteers to discuss that case? Let's see, there's lots of activity in the chat. Great. Kirtan would like to discuss. And I apologize, Kirtan, I can't tell by your name and I don't see your picture, just so we know for gender equity. Are you identifying as a man?
No.
Kirtan? Man, hi, I see you now. Okay,
yeah.
Thank you. So if we could have a woman who'd like to discuss with Kirtan, and then we'll need a case also. Anyone like to discuss with Kirtan? And does anyone have a case? Love to have someone identifying as a woman to discuss with Kirtan. Anyone, anyone? It's a lot of fun, we promise. Not to put anyone on the spot, but is there anyone who just matched in neurology on Friday and would like to try on your new neurology, take your new neurology match for a test drive this morning? And in parallel, does anyone have a case? Anyone? Who would like to discuss a case?
It's time for the awkward silence. Let's give it.
Yeah, all right. We'll leave the awkward silence. We don't want to leave Kirtan feeling lonely here.
That's true.
Well, Kirtan, you want to tell us about yourself a little bit while we wait?
Tell us where you're calling in from, and hopefully someone will be inspired to join you.
Yeah, so hello everyone. Myself, Kirtan Batolia. I am a final year medical student from BJ Medical College, Ahmedabad, India. And I just completed my internship. So I am looking forward to applying for match later this year. I already given my step 1 and step 2. So I'm looking forward to see how this match cycle will unreveal itself. And I have participated once previously, if I'm not wrong, around April 23rd previous year. And then I got so busy in my final year of med school that I didn't get time. And now finally I thought that it's a neurology VMR, so it's a good way to start.
Fantastic. We're so glad you're joining us. You said you're joining us from India. What part of India?
Yeah, so I am from the western part of India. So there is a state called Gujarat there.
In Gujarat.
So state of Gujarat, I am from Ahmedabad city.
Okay, fantastic. Welcome. All right, thank you. And we still don't have anyone ready to join you. Gabby, did you want to present a case? I know you have a case. Oh, Rafa, you have a case? You have a neurology case? Great, we have a case. Now we would just need a partner to discuss with Kirtan. I see Mario, I know you've discussed before, and ideally we'd like to have a man and a woman as discussants. Anyone? Anyone? Sukriti, all right, fantastic. All right, Sukriti, that is fantastic. Tell us, I think everyone knows you, but tell us where you're from and what's, where you are, and Rafa as well, and then we'll get started.
Hi everyone, I'm Sukriti and I'm calling from India as well. I'm from Bangalore. Very excited for today's VMR, but also super nervous because it's been a while since I've discussed.
But you've scribed and given so many teaching points that you're a neurology expert. Great team. And then Rafa, also a CP Solvers regular, but tell us where you're from and then we'll get started.
Hi everyone, my name is Rafael and I'm a MS3 from Brazil. Really excited to be here again with you guys. I've been away for a while, studying for my step one, which was last Wednesday, but now I'm kind of free and I'm here again with you guys.
Fantastic. And then Gabby and Travis are going to help us with scribing and teaching points. All right, so Rafa, if you can give us just the chief complaint, just the chief concern in as few words as possible, we'll get started.
No problem. So this is a 57-year-old male with altered mental status and ataxia.
Altered mental status and ataxia. Okay, Sukriti, do you want to talk about one or both of those chief concerns to get us started?
I can talk about the altered mental status. That's something we've talked about very frequently in the VMRs. And from what Rafa has told us, we just know the chief complaint. So in true Aaron approach, thinking about localizing the symptom as well as layering on the time course. So the way we think about altered mental status is thinking about if it's acute, we use our mixed mnemonic, thinking about the metabolic bucket, the infectious causes, the structural, and the toxin. If this was something hyperacute, it would put us in the bucket of a more vascular cause or something metabolic like a hypoglycemia. We'd have to rule that out because those are some of the pathologies that can be easily reversed, as well as some of the drug, like a drug symptomatology, like a drug causing this symptom. So looking for the reversible causes at first. If this was something more subacute to chronic, we'd also think about whether this was part of a more systemic syndrome or versus whether this was truly neurological. But given that this patient also has ataxia, we're really thinking about something more neurological at this point.
I'm muted. Sorry. Fantastic discussion, Sukriti, as always. So, right, we always want to start with the localization and the time course, right? Where in the nervous system are we? And then by knowing the time course, that's going to help us figure out what the problem is. So we're looking for the where and the what. And so the where here, if there's altered mental status, right, where something's going on with the brain, right? You can't get altered mental status from the spinal cord or peripheral nerves, muscles, neuromuscular junction, et cetera. So something going on with the brain, and then we have to think what can happen in the brain in these different buckets of time course. So what you said was perfect, Sukriti. So hyperacute in neurology, really all of medicine, right? What's hyperacute? What's sudden or instant? Vascular causes, so an ischemic stroke or an intracerebral hemorrhage. A seizure or a postictal state, right? Could be sudden. And sometimes patients have an unwitnessed seizure and they're just found altered. And in those cases, that could be a postictal state, right? So vascular, seizure, trauma, right? Again, if it was unwitnessed trauma and the patient has, post-traumatic confusion from a concussion or something like that. And then toxic metabolic, as you said, always important in every neurology chief concern, chief complaint, right? Is this a neurologic problem primary to the nervous system, or is the nervous system bathed in bad humors from something happening in the body, right? And you mentioned hypoglycemia, hyperglycemia, could be possibilities there, or a drug or an intoxication. What about acute causes? So I divide acute into hyperacute and acute, whereas hyperacute is truly sudden and acute is sort of fast, but not sudden. So over hours to days. So in that category, we think about infections, right? Could this be meningitis? Could this be encephalitis? That doesn't happen instantly, but emerges and evolves over hours to days, right? Could it be an inflammatory condition that can also emerge over hours to days? An inflammatory condition affecting the brain, like a flare of multiple sclerosis, or in children, something called ADEM, acute disseminated encephalomyelitis, right? Then there are also toxic and metabolic causes that can cause altered mental status over a more acute time course: acute renal failure, acute hepatic failure, someone who's been taking a drug or intoxicant or medication for a few days, and the effects emerge in that time course. And then subacute, could there be a mass in the brain, either a primary tumor or a metastasis, right? That's slowly growing in the frontal lobe or temporal lobe. Really, any lobe can give us confusion depending on how big it is and what it's pressing on and what we actually mean by altered mental status, right? And then there are some inflammatory conditions that can present over this time course as well of subacute, such as antibody-mediated or paraneoplastic conditions, right? So paraneoplastic or antibody-mediated encephalitis, right, could cause altered mental status. And then again, toxins, metabolites, right? If you have a slower course of renal failure, hepatic failure, et cetera. And then chronic, if this is really going on for years, we might think more about a degenerative cause here. And we think about degenerative causes of altered mental status, we might think about the degenerative dementias, right? Alzheimer's disease, frontotemporal dementia, dementia with Lewy bodies, et cetera. So this is sort of a rough pass, right? There's lots of other things, and we'll learn more in the history that can help us move through this. But for any chief complaint in neurology, hyperacute, vascular, seizure, trauma, toxic, metabolic; acute, infectious, inflammatory, toxic, metabolic; subacute, neoplastic, some inflammatory conditions. I didn't mention, but some infections, right, can lead into that category. Tubercular or fungal infections, neurologic complications of HIV tend to be more subacute, chronic. And then neoplastic, and then chronic degenerative, right? So those are all the different possibilities. And we'll also have to explore with altered mental status what that actually means, right? Is this a global encephalopathy where all the sort of mental functions are impaired, or does this patient appear confused to their friends and family, but the neurologist sees them and says, oh, actually it's aphasia. They're not confused at all. Their language doesn't sound right, it's aphasia. Or they're confused, this altered mental status is more of a behavioral presentation, more of a frontal presentation. So those are details we'll have to determine, both the time course and then where does this sort of localize within the brain as far as what type of altered mental status this is. Great. Kirtan, do you want to talk about the ataxia a little bit? What are you thinking there?
Sure. So I think you discussed all the important points. I am now just going to highlight few things which come to mind. So as you mentioned that it could be the metabolic cause. So it is important to consider whether we are dealing with some sort of vitamin deficiency, let's say thiamine deficiency or vitamin B12 deficiency, which can present as altered mental status, which can present as ataxia too. And always we think about ataxia, either it is due to cerebellar dysfunction, or it is due to the dorsal column dysfunction, or it is due to the large peripheral myelinated nerve fibers. So we can think about pathologies which can affect the peripheral nervous system and affect the CNS simultaneously, which can present in this manner. So vitamin deficiencies are one way to consider that. Apart from that, as you mentioned, in subacute and chronic thing, we can think about progressive multifocal leukoencephalopathy, which is affecting the cortex as well as the cerebellum. We can think about the prion disease. We are not sure what is the time status. Sometimes prion disease predominantly affects the cerebellum too. Sometimes, that is, if I'm not wrong, known as like Brownell Oppenheimer variant, something like that. So we have to consider the Creutzfeldt-Jakob disease under the neurodegenerative conditions. Then neurosyphilis is something that we shouldn't miss. It can present as ataxia as well as the altered mental status. As for the paraneoplastic phenomenon, I totally agree with you. We can be dealing with something like anti-U antibody, anti-TR antibodies, anti-HU antibodies. All of them can present as paraneoplastic cerebellitis. So we have to be aware of that. Then talking about some rare entities, we can occasionally come with something like Bickerstreff encephalitis, which can present in similar manner. Now it will be interesting to see if ocular findings are present or not. So we can start to put the pieces of puzzle together, and then we can see how it progresses further on.
Fantastic discussion, Kirtan. So, so many brilliant things there. And I just want to pick up on a couple of them. And then, as you said, we'll see which ones we want to zero in on as we learn more about this patient. So you're right, ataxia, this is the beauty of this framework. I mentioned this works for any chief complaint in neurology, actually any chief complaint in medicine, right? If you figure out where in the chest the problem is it heart, lungs, esophagus, chest wall, right? And you figure out the time course, these categories will generally work. So that all applies to ataxia. And you started us off with a very important point that, in my experience, many non-neurologists are not aware of, let alone students or interns. So brilliantly said, not all ataxia is cerebellar, right? If this it turns out to be a very cerebellar type case, we will delve into the anatomy in more detail, but the cerebellum helps to coordinate movements amongst other functions. And the cerebellum, to do that, needs sensory input from the body, proprioceptive input, which, as you said, comes from large myelinated nerve fibers through the dorsal columns, through the spinocerebellar tracts. And so the cerebellum needs that sensory input to coordinate movements. And so if you have a bound peripheral neuropathy, a sensory ganglionopathy, a dorsal column condition, the cerebellum can be fine, but it's not getting good input, right? So you could have what's called sensory ataxia. And when we get to the exam, we can talk about how you can actually distinguish sensory ataxia from cerebellar ataxia with a couple of interesting exam maneuvers. So we're going to have to think about localization-wise, is this a cerebellar problem, or is this a dorsal column or peripheral nerve problem, which each of those have a very different differential diagnosis, right? And so we're going to have to think about that. Since we have this altered mental status, presumably the brain is involved. So you started making some excellent Venn diagrams, right? If we have the brain and the dorsal columns, you could think about B12 deficiency, right? B12 deficiency causes a myeloneuropathy, meaning the spinal cord, particularly the dorsal columns and corticospinal tracts and the nerves. Copper deficiency can do the same. And B12 deficiency can also cause a progressive altered mental status, right? Even dementia in some cases. So having that Venn diagram of brain and spinal cord, or brain and ataxia, sensory ataxia, could make you think about B12 deficiency. Fantastic. Then you did the diagram of what if it's ataxia and altered mental status, could that be thiamine deficiency, right? Wernicke's encephalopathy, altered mental status, usually eye movement problems, nystagmus or gaze palsies, and ataxia, though many patients have less than 3 out of 3 of those, can be 2 out of 3, even 1 out of 3. So that's a great thought as well. You mentioned an important infection. If we find out this patient is HIV positive or otherwise immunosuppressed. PML, progressive multifocal leukoencephalopathy caused by JC virus. Usually the picture you're used to seeing, right, has these juxtacortical white matter lesions, no mass effect, no contrast enhancement outside of the context of iris. But you're right, it has a predilection for the white matter of the middle cerebellar peduncle that sort of curves from the pons into the cerebellum. One of my attendings who I trained under used to call that the shrimp sign, because it has that shape of a shrimp kind of coming from the pons into the cerebellum. So PML is something that could affect both of these cases. And then you mentioned, what about degenerative causes of dementia and cerebellar ataxia? Well, there are, I don't know how many spinocerebellar ataxias now. There are countless of these genes being discovered, but those patients have ataxia plus something else, and some of those patients can become demented as well. And then you mentioned Creutzfeldt-Jakob disease. We typically think about rapidly progressive dementia with myoclonus, but there is a variant that causes ataxia. I think it's the Gerstmann-Straussler-Schenker variant, which is actually one of the inherited prion diseases, but someone will have to double check me on that in the chat. I think you mentioned the Heidenhain variant that usually presents with actually visual cognitive dysfunction, if I'm not mistaken. These are super rare. I've never seen cases of them, but I think that's a great discussion. So we have a lot to think about here in terms of a differential, in terms of trying to understand through the history. The time course is really going to zero us in. What's meant by altered mental status, what's meant by ataxia, and then the context here, is there immunosuppression or not? And then of course, a lot's going to hinge on our exam determining where this localizes. Is this sensory ataxia, cerebellar ataxia? What are the cognitive deficits? Is there some way to explain all of this with one lesion? Is this multifocal lesions? We were trying a Venn diagram of one disease affecting both. A common disease that could cause both of these is stroke, right? What if the patient has a cardiac condition and throws multiple simultaneous emboli or emboli over time? And some of those cause problems with cognition and others go to the cerebellum. You could have a stroke with multifocal deficits as well. So is this going to be one underlying process, one underlying lesion, or is this going to be multiple lesions, multiple processes causing these two different presentations? Okay, fantastic. You gave us a lot to think about there in just a few words, Raphael. Can you give us more of the HPI now, and we'll go from there. Great discussion, Sukriti and Kirtan.
Yes, incredible discussion as usual. So I will go through everything until the physical exam, okay? So this patient's wife brought him to the emergency department due to worsening confusion. He is presently unable to respond to questions appropriately. She first noticed him exhibiting mild memory problems 3 months ago. These difficulties have progressed since that time. Since then, his ability to carry out his ILDLs and ADLs independently has declined. At one point, he was seen by his primary physician. A metabolic workup was unremarkable. A urinary culture was positive for E. coli, prompting a course of antibiotics. This had no effect on his decline. A CT scan of the brain revealed possible hypodensities in the periventricular regions, and his family physician instructed him to begin taking ASA and submitted a referral to neurology. Appointment still pending. Over the past 2 weeks, his speech has slowed and he has grown more confused. Over the past 24 hours, he has been able to speak in 1-2 word bursts only. Over the past 3 months, the patient's gait has become slower and wide-based. His left leg has seemed to be weaker than his right leg over the course of the past 3 months. And his wife believes that he has developed gradually. And more recently, he has difficulty using his left hand and arm, and he has suffered multiple falls over the past 2 weeks. This patient has no head trauma. When it comes to history of past medical history, this patient has Crohn's disease. He was diagnosed at 22, very well controlled with medical therapy until 3 years ago. Worsening symptoms at the age of 54 required escalation of medical care, and his symptoms settled after combination therapy with infliximab, azathioprine, and prednisone. And he required ongoing combination therapy to maintain disease control, and no recent flare in symptoms. This patient has no other medical comorbidities and no additional medications, apart from recent initiation of ASA. This patient is a non-smoker and he has a social ethanol intake and no relevant family history. And that's the end of aliquot number 2.
Okay, so just to make sure, since I know you had a lot of information there, Travis is still catching up with you. Patient has a prior history of Crohn's disease. The problem that he's presenting for began about 3 months ago and has progressed. It's a problem with cognition, ultimately leading to very little verbal output. And then there's a gait disorder as well. Somewhere along the course, there was a UTI treated with antibiotics. Did I miss any of the details there for Kirtan and Sukriti?
No, it's excellent.
Great. What do you think, Sukriti?
Just a little reminder.
Yes.
Just to remember that this patient over the past 24 hours has been unable to speak properly.
I see. So he was speaking up, he was progressively confused for 3 months, but speaking okay. And then 24 hours ago since then has had difficulty speaking.
Exactly.
Okay. So just to make sure for our discussants, before 3 months ago, he was a normal person, about, as best we can tell. 3 months of progressive confusion, a day of speech difficulty, and somewhere along there, progressive gait difficulty, but that was not sudden.
Yes, exactly.
Okay. What do you think of this, Sukriti?
I'm a little overwhelmed with the information, but I think what stands out is first addressing that this patient has this prior history of Crohn's. So keeping that as a background and then thinking about whether his present complaints are a result or a consequence or associated with the Crohn's, or is this just a new pathology? And then the second point is that this patient his initial symptoms started with a memory problem that is quite it's quite quickly progressing. 3 months isn't very long, and his age again doesn't support like a degenerative disease. And now, just layering on this acute complaint of the verbal output and the gait disorder, um, sort of makes me think about like a vascular problem. And if I had to put it together, then one of the theories I would have was that he's had like multiple infarcts over time, and maybe the speech is an acute result of one of these things. But at this point, it's still keeping all the differentials open and not closing in on anything. And the other is he's also immunosuppressed given his Crohn's. So also infections would be high on my list. And then thinking about which infections would progress so subacutely and then worsen quickly.
And that's a brilliant discussion as always, Sukriti. And what infections would you have in mind in an immunosuppressed patient that could progress in this sort of subacute time course?
I think fungal and viral infections would be at the top of my list. Bacterial would be less likely. If we think about if we really think that this whole syndrome has one explanation, and that the memory problem and the recent speech problem is related. But if we think that if we're just looking at the speech and the recent gait, then maybe we could still entertain like a bacterial pathology.
Yeah, great thoughts. Great thoughts. So, as we mentioned from the beginning, before we knew all this context, right? In general, when we think of infections, we think of things presenting in a more acute time course, hours to days, but that more specifically is really bacterial and viral infections, right? As you know, from having the flu or, you know, a cold, right? That's a viral infection, kind of emerges, peaks over hours to days, and then recedes. Similarly, a viral neurologic infection like herpes encephalitis, or a bacterial infection. We've all probably had strep throat, right? That doesn't come on suddenly. It doesn't last for months, right? So bacterial meningitis, those would tend to be quicker than this. But this time course of emerging and evolving over months would make us think about tuberculosis or fungal infections or neurologic complications of HIV in general. Now, coming to this patient, you picked up on a lot of very important clues here. As you said, Sukriti, the history has a lot in there, right? And there's a lot we're going to have to piece together. Is there, as you astutely pointed out, is there a subacute process and there's an acute process superimposed on top of that? Are those the same underlying process, right? Is this patient having multiple strokes over time, and this new sort of acute presentation is itself a stroke, and the patient's been having ongoing strokes for a reason we're going to have to determine? Or is there some other process that has now been complicated by stroke as a sequelae of that underlying process, like an infection, as you mentioned? And then you pointed out, obviously, the very important concern here that this patient is immunosuppressed, right, on infliximab, on azathioprine, on prednisone. So that broadens our differential and makes us particularly concerned for infections. So can you think of, Sukriti, or can you think of, Kirtan, would there be any way to relate a neurologic infection that could be presenting subacutely with a superimposed stroke? Or I'm sort of playing guess what I'm thinking, I guess, but any way you could relate, this is immunosuppressed patient, so we could be wrong, but a lot of our attention is now going to not missing a subacute infection. So any way you could relate a neurologic infection and stroke, or in general, a systemic infection and stroke? Any way to connect those two dots? Any thoughts?
Yeah, so excellent. Actually, I love the vasculitis thing. So this is going to be very interesting for me. So when we talk about the infections and how they interplay with the blood vessels, then there are certain organisms which have predilection to involve the blood vessels, right? So we usually talk about things like aspergillosis, mucormycosis, cytomegaloviruses, then some sort of tuberculosis infection can also actually cause vasculitis pathology, and that can explain the multiple hypodensities that we are looking at the periventricular lesion, which were visible on CT scan. So we can think about those possibilities. And aspergillosis can, of course, come in the immunocompromised patients. So that is a nice way to think of. And another possibility, which Sukriti and you mentioned, that what if we are throwing off emboli from the heart? So let's say if we are dealing with subacute to chronic endocarditis, So that is very nice to think about, that what are the organisms which can cause subacute to chronic endocarditis and can also involve the blood vessels. So let's say Bartonella is there, Q fever is there. I know it's a little bit of a stretch, but we have to consider those possibilities as of now. And let's say for a moment that if it is not infection, then what can explain all these multifocal infarcts and which is progressed over 3 months and now presenting acutely with speech disturbances? So something like primary CNS tonsillitis, actually it presents over course of months to years, but sometimes it can present over course of 3 months. So it's not too far-fetched that primary CNS tonsillitis can present as multiple periventricular hypodensities. Then regarding infections, we can always think about toxoplasmosis is there or not. MRI can shed a better light on those possibilities, whether Riem-enhancing lesions are seen or not, whether T1, T2 weighted sequence, how they reveal the answers. So MRI can give us more findings, that whether it is toxoplasmosis, whether it's cryptococcal meningitis. And neurocystic sarcosis, it's a little bit far-fetched too, but neurocystic sarcosis can present in this way. It can also affect the cerebellum. It can also affect the speech regions. So it can present as acute loss of speech. And just to make sure about the speech disturbances, now what can cause speech disturbances? I mean, is it related to temporal lobe? Is it related to the brain stem? It is related to the bulbar nerves. I mean, why the patient is not able to speak all of a sudden? So what I can pursue as of now is that we might be looking at generalized cortical dysfunction, which might be responsible for speech disturbances, or probably some sort of brainstem pathology, which is overlapping on the cortical and cerebellar pathologies. So let's see what lab findings reveal, and then we can probably zoom in on whether these are infections or some sort of autoimmune conditions which can explain all these findings.
Fantastic discussion. Great. Brilliant thoughts. So right. Meningitis can be complicated by stroke, right? Classically, tuberculosis, fungal meningitis, meningovascular syphilis, right? The meninges that are affected in meningitis, particularly most commonly in infectious meningitis, the leptomeninges, meaning the pia and arachnoid. Remember, the circle of Willis and the vasculature is in the subarachnoid space, right? So if you have the infection and inflammation of the meninges, this can lead to, as Kirtan said, a secondary CNS vasculitis and infectious vasculitis. This can happen in bacterial meningitis as well, but often that's identified sooner since it's so acute, treated early, and at least in my experience, less common than with tubercular or fungal meningitis, where strokes are relatively common. So do we have a subacute infection that's been complicated by a secondary infectious vasculitis that's been complicated by a stroke to explain the subacute progression, and then an additional step here? You mentioned infectious vasculitis, such as that due to aspergillosis, mucormycosis, VZV. Those are all great thoughts. In principle, at least in my experience, those are very aggressive infections, and so I might have expected a more aggressive course than, excuse me, one that sort of trickled along for 3 months, but it's something to consider on the differential. And then what if this patient has a subacute infection, a subacute systemic infection like endocarditis, and then the organisms here with an immunosuppressed patient could be essentially anything, and is having secondary progressive infarctions there. That CT finding of periventricular hypodensity is a little hard to interpret. That's a very common place to see hypodensities in patients with vascular risk factors. This patient doesn't have vascular risk factors, is relatively young, so it would be hard to know what to make of them, and are those actually part of this process is something that's interesting to consider. You mentioned neurocystic sarcosis. This probably wouldn't be a common presentation for that condition. Usually the lesions are very small, don't cause focal deficits, they cause seizures or headache, but every once in a while you can get a large cyst that can cause particularly focal deficits. So I think those are great thoughts. It's hard to pull ourselves away from an infection, right, given this patient's immunosuppression. Backing up, is there any Venn diagram of Crohn's disease and neurology? So inflammatory bowel disease in general is, someone from medicine can correct me if I'm wrong, I believe predisposes to a hypercoagulable state. So these patients can be predisposed to venous sinus thrombosis. I believe Pachy meningitis, so a dural meningitis, inflammatory meningitis, has been reported in inflammatory bowel disease as well. Someone would have to check me on that. So that condition itself can have some neurology associated with it. The medications he's on certainly can have due to their immunosuppression, the sequelae of opportunistic infections or other infections. And then something else you mentioned, speech, right? So you made the excellent point, is this a language problem or a speech problem? And what do we mean by that? So if the patient has normal language, meaning their cognition is intact, if they have anything affecting the musculature that allows us to speak, they could be dysarthric, right? And so if you have a facial palsy from the seventh nerve, right? So if I can't move one side of my face, right, I can have dysarthria. If I can't move my tongue, I could have a lingual dysarthria, right, from a 12th nerve palsy. If I can't move the muscles of my larynx, right, from cranial nerve 9 and 10 palsies, I could have dysarthria, right? And you can test those on exam if you ask the patient to say p, 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 p. That's a labial sound using the lips. That looks for labial dysarthria from facial weakness. You can have them say la, 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 la. That uses the tongue, right? You can look for lingual dysarthria from that sound. So that would be a problem with the pathways innervating the tongue. Or you can have them say ga, 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 which is a guttural sound. And guttural dysarthria would be from a lesion of cranial nerves 9 and 10, or their pathways in the brainstem. So if this is not really a speech problem, but ataxia and dysarthria together, that could be a package for the cerebellum, right? Or maybe all the speech apparatus, its cranial nerves, its control in the brainstem and cerebellum is fine, but we have a lesion upstairs in the brain that's causing a language problem. I should mention also a lesion in the brain, right, can just affect the motor pathways and cause dysarthria, but a lesion in the language areas, such as Broca's area or Wernicke's area, could cause a problem with language where the speech apparatus works, but the ability to create words and use them appropriately is affected. So we have a lot we're going to be very curious about on this exam. Are there meningeal signs to suggest that there's an infection? Does the patient have ataxia, or is the patient just sort of weak and sort of generally weak and such that it's a gait disorder that is not ultimately ataxia? If they are ataxic, is it a cerebellar ataxia or a sensory ataxia? Is this speech problem generalized confusion? Is it a focal language deficit, or is it a dysarthria? We have a lot of things to explore here in the physical exam. And I did see fly by on the chat antibiotic encephalopathy, one of my favorite topics, right? I think the more information we got, the less likely that became. But antibiotics can actually cause altered mental status. Cefepime is a common culprit, I should say. Not common given the amount of cefepime that's used in the inpatient setting, but common to a neurologist consulted in a patient who's confused and on cefepime, particularly in patients with renal failure. It's a very striking syndrome. The patients are very confused, a little bit agitated, often have myoclonus and tremor. There's an encephalopathy associated with metronidazole, which can also cause cerebellar ataxia, actually. So you can get cerebellar toxicity from metronidazole. So again, I think we have too much here to blame the antibiotics, but had we not heard all of that stuff in the bottom left corner there, and this was just a patient who had a UTI and was confused, delirious from that, and then got antibiotics and got worse, we'd have to think about antibiotic encephalopathy. So great. So lots is still on the table here. I have to say, for me, it's hard to pull away from immunocompromised. We don't want to get too strongly anchored there, but immunocompromised, the subacute time course really makes us concerned about a fungal or tubercular infection here, such as a meningitis with secondary infarction if that speech problem is really sudden. But we have to keep our differential diagnosis broad still, because this patient has an underlying systemic disorder, is immunosuppressed. Clearly from that scan has some evidence of vascular pathology, so maybe there's some other reason this patient has predisposition to stroke, even beyond the possibilities we've mentioned. Great, so let's hear more about the exam and see how that helps us, but obviously this is a patient who's going to need some brain imaging, and probably if we don't have a clear diagnosis there, some spinal fluid, given the immunosuppressed state and risk for infection. Okay, what was found on the exam, Rafa?
Okay, so I'm gonna give you the physical exams and the initial labs. So the vitals, the heart rate was 78, the blood pressure was 145/80, respiratory rate 12, and he was saturating 99% room air. And the temperature was 36.9 Celsius. This patient appears chronically unwell and confused. Mental status, slow to respond to questions and manages to speak only 1-2 words at a time. When it comes to the head, neck, cardiac, pulmonary, abdominal examinations are all were unremarkable. No murmurs, no carotid debris. And when it comes to neurological examination, limited examination due to patient's inability to understand instructions, no obvious cranial nerve abnormalities, moving all 4 limbs spontaneously, but weakness against resistance, 4+, noted in left arm and leg, deep tendon reflexes difficult to obtain globally, and the plantar responses up going bilaterally. This patient also had a slow, wide-based, unsteady gait, and dysmetria and dysarthria present, particularly on the left side of the body. When it comes to the MMSE, 17 out of 30. Just the lab, some previous labs. The hemoglobin was 11.9.
Oh, sorry, Rafa, just quickly on the exam, did we get the cerebellar exam and sensory exam, or did I miss those?
There was dysmetria and dysarthria present, particularly on the left side of the body.
So there's right-sided weakness in the arm and leg, and left-sided dysmetria and dysdiadochokinesia, is that right?
This patient actually had a weakness against resistance in the left arm and leg.
So all the deficits are on the left side.
Yes, exactly.
Okay, so left weakness and cerebellar findings on the left side, normal sensory exam, and reflexes, you told us the plantars, but do we have the tendon reflexes or no?
No, the tendon reflex. The deep tendon reflexes were difficult to obtain globally.
Okay.
So just the initial
unsteady and wide based, is that right?
Yes, slow, wide based, and unsteady.
Okay. You wanted to give us more, or should we discuss the exam?
Yes, I'm going to give you all the exams before the CT and the MRI. Okay.
Actually, let's stop there if that's okay, just to focus on the exam.
No problem. It's up to you.
That's okay. Yeah, I think I know why you want to do that, but let's let's give our discussants a chance here first. Sukriti, what can we do with this exam? Anything localizing for you, and how would you put it together with what we've been thinking about?
The fact that he has left-sided weakness and the left-sided cerebellar signs, I think that puts us on the right side of the brainstem, but I'm not sure if I'm correct on that. As well as layering on the slow, wide-based, unsteady gait. Again, that tells us that we're dealing with true ataxia. This was one of the things that we discussed. The other thing that we discussed was looking for meningeal signs, and doesn't look like he has any meningeal signs. And then again, we talked about whether this speech was a language problem, a dysarthria, or like a generalized weakness. So I think this would put us in the bucket of like a dysarthria, and again, suggestive of like a brainstem lesion on the right side.
Great thoughts. So yeah, there's a lot here, and it's I'm not sure we quite got enough information to know dysarthria or aphasia. Rafa, were the words that were spoken, were they clearly articulated? Do we know, or is
actually there is no description?
No problem. Yeah, if the patient is just dysarthric, presumably they would speak as many words as they could. They would just be hard to understand. So if it's so few words at all, hard to know if that's, as you said, Sukriti, a global confusion, or could the patient be aphasic with a Broca's aphasia, a non-fluent aphasia, and so not able to produce many words at a time. Hard to know. And then, as you said, we have problems in the left arm. When you hear that the left arm is weak, it's hard to judge ataxia, right? Because if the arm is very weak, the arm can be a little bit tremulous. You know, if you try to lift a heavy object and you get a little bit shaky, right? If the arm is weak, doing something that's even wouldn't require much strength for us, can make the arm look a little bit shaky and dysmetric. And so that can be a little bit hard to interpret. You mentioned earlier the cerebellum needs this proprioceptive input, right, to do its thing. It also needs motor input from the brain to tell the cerebellum what the plan is, right? So we may as well just finish the job here. The cerebellum needs two inputs and one output. The cerebellum is coordinating movements. So it needs to know where the body is in space. That's proprioceptive information from the dorsal column pathway. It also needs to know what the brain wants the body to do. That's the motor plan, which comes from the cortex. And it takes that information and says, well, if you're here and you're trying to do this, this is the answer to that equation, and it sends that information back to the brain. So I always think of it like if you're the soccer goalie about to catch the ball, right? And they show that beautiful catch in slow motion, right? That there's sort of a lot of initial positioning, and then at the last moment, there's stuff that happens really fast. And I always think that's the cerebellum saying, where am I? Where do I need to go? Where am I? Where do I need to go? I'm here, need to get the ball. Here, need to get the ball. And that gets you there. And those two inputs and one output correlate to the three paired cerebellar peduncles, right? The inferior cerebellar peduncles bring in information from inferiorly, which particularly the proprioceptive information as well as vestibular information. The middle cerebellar peduncles bring in information from the brain to know what the motor plan is. And then the superior cerebellar peduncles send information back to the brain to complete the circuit. So cerebellum knows where you are, what you want to do, makes its calculation, sends it back to the brain. And if you remember those three functions, 2 in, 1 out, you can pair those with the three paired cerebellar peduncles. So that's a kind of nice mnemonic way of remembering what those do. There are some exceptions to what goes in, what goes out, but those are the main ones. So if the patient has a right brain lesion, as you said, they could have left-sided weakness. And depending on where that lesion is, those same corticospinal tracts traveling with them are the cortico-pontocerebellar fibers, which are going to go to the pons. And then instead of continuing in the corticospinal tract through the pyramids, crossing and then going through the spinal cord, they're going to send what I call a CC, like an email. They're going to CC the signal to the cerebellum, cross to the other side. So the cerebellum has ipsilateral deficits, so a left-sided cerebellar hemisphere lesion would cause left-sided ataxia, right would cause right-sided. But as you said, Sukriti, if you had a right-sided brain lesion or upper brainstem lesion, you'd be getting fibers that are destined both for the left arm and left leg, lower motor neurons in the cord, and the left cerebellum. So it seems like we have at the very least something going on in the right brain. If this patient is right-handed, their speech should be on the left side. Actually, in almost all left-handers as well, speech is on the left side, but it can be bilateral or right-sided in left-handers. So we have at the very least a right-sided brain lesion. And if it's a big lesion, that could cause also facial weakness on the opposite side, tongue weakness on the opposite side, laryngeal, pharyngeal weakness on the opposite side, and some either ataxia in the setting of weakness or some true ataxia from the cortico-pontocerebellar fibers. So at the very least, there's a right brain lesion here. Whether there are additional lesions to explain all of this, or is this one big lesion with mass effect, or is there one sort of predominant lesion and a lot of little ones that are causing in aggregate a global encephalopathic state with some focal signs superimposed? A little bit hard to tell from the exam alone. And that mini mental status is quite low. It can be hard to interpret as well, because with cognition, you have to think of it as sort of a series of doors, right? You have to have attention first. If you don't have attention, you can't form a memory. And if you can't form a memory, it's hard to have a normal conversation, right? So your language could be abnormal. So if this patient is globally encephalopathic, delirious or encephalopathic, and has impaired attention, it's really hard to interpret memory, right? So if you think of, you're on a Zoom meeting, right? And you're texting on your phone, not paying attention, right? And someone says, oh, would you like to share your thoughts? And you look up and you think, oh, what did they just say? It's not because your memory doesn't work. It's not because your language doesn't work. It's because you weren't paying attention, right? So hard to interpret that mini mental. Is there really multifocal deficits here, or just a global attentional deficit that's impairing everything else? So a little bit hard to say. I'm not sure this moves us forward. We know that there is at least one focal lesion, presumably in the right hemisphere. Given the global state of deficits, there's probably multifocal lesions, and that may be one amongst many. And so I'm not sure it helps us too much in narrowing our differential, because depending on what that lesion looks like on imaging, presumably we'd still be concerned about whether it's infectious or not. Okay, Rafa, you wanted to give us some labs, you wanted to give us some imaging. Before we start getting this data that's going to get closer to the final diagnosis, Sukriti and Kirtan, do you want to wager what the final diagnosis could be. I'm not sure we have enough information, and this is where the imaging and other data are going to help us, but a problem representation and a possible diagnosis. What do you think? I think you were first last time, Sukriti. What are you thinking here, Kirtan?
Yeah, so I agree with you. It's a little bit difficult to jump to the conclusion just now without imaging studies, but I think we have got all the possible points. Just one possibility I wanted to mention, that what if this patient has, let's say, diffuse metastasis all through the brain? I mean, we are talking about multiple lesions. As from the history, we don't have any evidence of smoking or anything which can predispose him to have cancer. But still, we have to consider that whether this is a metastatic lesions are there, then they can produce such widespread neurological deficits and sometimes focal neurologic deficits. So we have to consider that. Apart from that, we talked about the endocarditis. So it could be infectious endocarditis, but what if it is meningic endocarditis? Then still we can get this sort of picture. We can get various emboli throwing off here and there. And it turns out that it is not infectious, but it is actually due to a cancer. And hematologic malignancies are a little bit rare to mention in this manner, but diffuse large B-cell lymphoma is something on the back of mind. I know we don't have evidence of B symptoms, that the patient has fever, hepatosplenomegaly, something like that. But still, just to wind up our discussion, just to get a clear picture, we need to consider that metastasis, endocarditis, meningic one, and malignancies, hematologic, we are not missing that. And as of problem representation, I agree with you and Sukriti that it's a little bit difficult to say as of now. Let's see, probably imaging findings or hematologic parameters will give us some clue.
Great thoughts. So we are in the subacute category. As I said, we are really concerned about infection given the immunosuppressed state, but we have to keep a broad differential. And what else falls into that subacute category? Well, malignancy does, doesn't it? Now, someone from internal medicine can correct me. My understanding, if I'm remembering correctly, I don't know if Crohn's increases the malignancy rate. I know ulcerative colitis certainly does, but if Crohn's does, is there a GI malignancy here and with metastases to the brain, or a GI malignancy causing a hypercoagulable state, causing, as you said, non-bacterial thrombotic endocarditis, a possibility we mentioned earlier, right? And even without malignancy, my understanding is Crohn's causes a hypercoagulable state. And so this patient could also just be predisposed to having this hypercoagulable state and having non-bacterial thrombotic endocarditis and strokes as a result. And then you mentioned the other possibility in an immunosuppressed patient thinking of neoplasia, could this be a primary CNS lymphoma, right? As we can see in immunosuppressed patients. And that could fit this time course as well. So the characteristics of the lesion we'll see on imaging are going to help us here. So you're still thinking in the infectious category, even with respect to malignancy, right? Because you're thinking of an EBV-associated malignancy, or is this immunosuppressed history not relevant here, and we're more concerned about a neoplasm? And I agree, both are on the table. Probably the only etiologic category taken off the table, right, is an inflammatory condition, because this patient on so much immunosuppression, it'd be hard to imagine them developing an inflammatory condition when they're immunosuppressed, right? What are you thinking, Sukriti, before we get the data that's going to likely answer this for us?
I don't really know, very honestly.
Yeah, I don't really know either. I think that's a wise point. We can make our guesses for roundsmanship here, right, based on the general problem representation of subacute neurologic deficits in an immunosuppressed patient, but this could still really be anything. And the exam has helped us localize somewhat, but given that we had confusion from the beginning, we knew we would be getting brain imaging. So, you know, neurologists are very attached to the exam and saying it's very eloquent, right, in helping us localize. And I think it most often is. But in this case, I think we know from the beginning that brain imaging is going to be needed here. So, okay, Rafa, tell us the labs and the imaging, and then before telling us what the actual diagnosis is, we'll see if we can incorporate that imaging to understand what the final diagnosis might be.
Okay, so I'm gonna give you all the data before the final diagnosis. So the hemoglobin was 11.9, the white blood count was 4.3, and the platelets were 263. And the calcium, magnesium, phosphate, renal function, liver panel, IRNR, PPTT were all within normal limits. The glucose was 94, the albumin was 2.9, the B12, the folate, the TSH, the T3, the T4, the ferritin are all within normal limits. The ESR was 36, being the normal from 1 to 20, and the CRP was 54. ANA was negative, and blood cultures for HIV, Lyme, VDRL were testing all negative. The CT had, with no contrast, no acute findings, patches of hypodense white matter changes in subcortical regions bilaterally, not typical of ischemic lesions. And the MRI showed multiple areas of decreased signal on T1 images, particularly prominent in periventricular and deep white matter areas, consistent with areas of demyelination, and similar lesions believed to be present in the cerebellum, and little edema surrounding these lesions, no mass effect. And finally, a lumbar puncture was made, and the opening pressure was 16, the cell count was 80, predominantly leukocytes, and the glucose was 67, and the protein was 62, and no growth was obtained from culture. And that's the end of Aliquot before the final diagnosis.
Okay, so we have multifocal white matter lesions in the brain, and a lumbar puncture. Sorry, everything was flying by and being typed in different time frames. The lumbar puncture was normal opening pressure, elevated protein in the 100s, and then the glucose and cells were what? There we go.
Glucose
Glucose
was 67, being the normal 40, 70, and the protein was 62.
62, and
Yes.
80 white blood cells that were predominantly, do we know if those were lymphocytes or?
Leukocytes.
So they're white blood cells, but are they lymphocytes or are they polymorphonuclear neutrophils? Do we know?
Actually, there is no description, but I can help you showing the image if you want to see the MRI.
Sure, would love to see the MRI. Yeah.
Can you make me a co-host?
Oh, I'm sorry. Yeah. While you're pulling up the imaging, Sukriti or Kirtan, what are you making of this this data?
Sukriti, you can go ahead.
Oh, I don't really know how to interpret the MRI, Aaron.
Me neither.
No, I think if I saw correctly, the ESR and CRP was elevated. So that just put us in the inflammatory bucket, but then again, it can be like an autoimmune process or an infectious process, but I don't really know what to make of it.
Yeah. Is this the one image you have, Rafa? Just one image, just so we know? Yeah. Yeah. Okay, great. Kirtan, any thoughts?
Yeah. So I think the fact that these are periventricular lesions and these are hyper intense on T2 weight imaging, and as the report mentioned that they are suggestive of demyelination, we might be looking at progressive multifocal leukoencephalopathy. Now, as we discussed earlier, usually it is associated with HIV, but then there are certain medications which can cause it, like natalizumab or rituximab. I know in our case, those are not mentioned, and I'm not sure whether infliximab can cause PML-like syndrome, but PML is something we have to consider. And apart from that, I don't think this pattern of MRI, I'm not sure whether it fits anything else. There is only one thing which I had read like few years back, that sometimes cerebral amyloid angiopathy can present as vasogenic edema kind of state. It's super rare, and I don't think it particularly presents in periventricular manner. So I'm not sure. I mean, help me out. Is this suggestive of PML or is this something else?
This is suggestive of PML, absolutely. Yeah, so when you hear periventricular or white matter lesions without seeing the image, if you can leave the image up, Rafa, because I think this is important to look at. Yeah, you might think of multiple sclerosis or something like that. But what's characteristic about PML are a couple things. One is it'll be bright on T2 or FLAIR imaging, but if we can put the image back up, that would be great for people to see. But it goes right out to the cortex, right? And in this case, as you saw, it really goes right out into the U fibers, the fibers that are when we say subcortical, we often mean deep juxtacortical, meaning right along the edge of the cortex and sort of runs along the gray-white junction. And despite this being a very large lesion, I know you can't see my arrow, it's not causing any mass effect, right? If there was a tumor there, an abscess, a toxoplasmosis lesion, there'd be a lot of inflammation around that, and we would see the ventricle being compressed, whereas the ventricle is normal on that side. And so that lesion does look very characteristic of PML. You can see it going right into every little fold of gyrus there, but not actually affecting the overlying gray matter. And so this is a very characteristic view here. So MRI, just like chest X-ray, left and right are flipped, right? So we know this patient had left-sided deficits. I think we have a good explanation for those. And this indeed looks like PML with this preference for the white matter, right? Leukoencephalopathy, and then this sort of juxtacortical pattern, and then large lesion with no mass effect, right? So if you get iris, as I saw mentioned in the chat, right, immune reconstitution inflammatory syndrome, you can get contrast enhancement, mass effect, kind of all bets are off. But this is a very characteristic appearance for PML. It's progressive, right? Check, this patient has a progressive neurologic problem, right? It's multifocal, right? We see right-sided and left-sided lesions here. And it's a leukoencephalopathy, and this patient is immunosuppressed. So, right, HIV, I don't know if that was the first population in which this was described or not, but certainly a common one. Post-transplant is very common. And then with our new MS drugs, like natalizumab, the rate is very high. And then I don't know with these particular medications, as far as infliximab, if there's an increased rate, but certainly being on multiple immunosuppressants here, immunomodulatory agents, I think that would make PML most likely. So there's a slightly elevated protein. There's a lot of cells. That's sort of a non-specific pattern here, but probably too many cells for this to just be an inflammatory condition makes us think of an infectious one. So to me, that certainly looks like PML. What was the final diagnosis here, Rafa? Are we on the right track?
Of course you are. So it was positive for JC virus, and the patient's clinical presentation, so acute neurological deterioration, imaging findings consistent with demyelination, and history of immunosuppression raised concerns of progressive multifocal leukoencephalopathy. And given that suspicion, the positive PCR results for JC virus in his CSF were felt to be diagnostic of PML. And early concerns of embolic stroke became less likely as a result of the MRI, and the LP returned, given the absence of acute onset of his deficits. And a possible brain biopsy was discussed, but his substitute decision makers ultimately decided against this investigation, and his immunosuppressive agents were discontinued following consultation with the gastroenterologist. And through the tempo of his progression slowed, he continued to decline over subsequent weeks, and he and his family eventually pursued a fully palliative philosophy with a focus on comfort.
Right. Yeah, this is unfortunately when patients develop this, whatever the context, it's very hard to treat. There's some in vitro data from mirtazapine, the antidepressant, blocking JC virus entrance into cells. Some people use that empirically, I believe, if I'm not mistaken, antimalarials as well, but there's no convincing clinical evidence. Two recent papers in the last few years have suggested the use of, if I'm not mistaken, pembrolizumab, and another paper looking at, I think, CAR T cells, if I'm not mistaken, as potential therapies that have been very successful in small groups. These are in the past 2 years. These are papers on my reading list, so I'm just trying to visualize the titles. The first author in one is Cortese, the other one begins with an M, Muftioglu, something like this. Maybe someone can put them in the chat, but I believe studying pembrolizumab in one case and virus sensitized T cells in the other. Someone can correct me if I'm wrong, but so a very devastating condition, and one in which there's active research trying to figure out how to treat this condition. So wow, what a diagnostic journey here, right? We started out with altered mental status and ataxia, and we talked about those individually and together. We talked about what could be causing both, such as vitamin deficiencies or multifocal processes or underlying systemic processes causing multifocal strokes. We talked about meningitis and secondary vasculitis, right? But I think the pivot point in this case was hearing that this patient was immunosuppressed, which really zeroed us in on atypical infections. And Although when we think of hyperacute, acute, subacute, chronic, we often put infection in that acute block. We have to really remember that that is bacterial and viral for the most part, and subacute infections can include fungal, tubercular, and this particular virus, which is one you might not think of in subacute time course, which is JC virus causing PML. And then really the answer in this case came from the neuroimaging, right? That very characteristic pattern of a large lesion going right out to the gray-white junction, but not causing any mass effect, and being progressive, multifocal, and leukoencephalopathy. A positive JC virus PCR in the CSF would be sufficient to make that diagnosis. And unfortunately, as we discussed, one that's very hard to treat, but some potentially promising emerging therapies. So great presentation, Rafa, very complicated case. Sukriti and Kirtan, excellent discussion at each level to try to narrow, first broaden and then narrow, and then broaden and then narrow our differential again, and think of all the different ways that patients can develop altered mental status or ataxia, that patients can, with immunosuppression, can develop these symptoms, that patients with Crohn's disease can develop these symptoms and ultimately converge on an opportunistic infection. Great. Gabby, do you want to close us out with some teaching points? And while you do that, I'll look up these two papers and see if I'm said the right thing or can correct myself.
Great, Rafa, thank you for the case. Thank you for the discussions. As always, so we had a lot of teaching points from this case. First, we had to approach a patient with altered mental status, and we have to first check if this person has a true altered mental status, and we have to differentiate this from other possible differentials like global encephalopathy, confusion, aphasia, or behavior changes. If this person has an altered mental status, this localizes to the central nervous system, specifically to the brain. And we remember that the neuro DDX is equal localization versus time course, and we already have our localization here. And then we have to think about hyperacute, acute, subacute, or chronic causes, and we will have a very high list of all the possibilities. I'm not going to read everything for you, but we have to think about the time course to find the diagnosis. This patient also had ataxia, and about ataxia, we have to think about two causes of ataxia, cerebellar or sensory ataxia. The sensory ataxia is caused by dorsal column or proprioception defect. And if we think in a disease that has overlap brain plus dorsal column, we have to think about two deficiencies here, mainly, which are B12 and copper deficiency. Also, we talked about the approach to infection and stroke, and we have to think about systemic infection or specifically a CNS infection. For systemic infection, the biggest cause is endocarditis, and for CNS infection, we will also have to think about the time course. Is it acute, more commonly due to bacteria or viruses, or if it is subacute, we have to think about fungi infections like tuberculosis or meningovascular syphilis causing vasculitis. We have a lot of other fungi and viruses that can cause stroke plus infection, and we cannot exclude everything right when we were seeing the case in the beginning. We also talked about other things important here that we have to differentiate between language and dysarthria. There are a lot of causes of dysarthria, including neurologic or non-neurologic causes. We have to remember that for motor and sensory symptoms, it causes a contralateral deficit, but for cerebellar lesions, we'll have an ipsilateral deficit. And the final diagnosis was progressive multifocal leukoencephalopathy, PML. And we thought about this after, mainly after seeing the image. This person was immunosuppressed, and she had periventricular lesions right onto the true flare up to the cortex and no mass effect. This disease is due to demyelination with a positive JC virus. Thank you, everyone.
Great. Thank you, Gabriella. Fantastic summary. Raphael, really difficult and challenging and interesting case with great division of material so that we could think through each step and have an interesting discussion about many topics. And Sukriti and Kirtan, really phenomenal clinical reasoning through a very difficult neurologic / infectious disease / immunologic case. And I just put in the chat before we close out because I was questioning, since I only saw those papers once, if I remembered them correctly. There's one New England Journal paper for T-cell therapy for PML and another for Pembrolizumab. And then a point I always like to make, Kirtan had mentioned primary CNS vasculitis. That's an extremely rare diagnosis, and in my experience, often misdiagnosed and overdiagnosed by overzealous radiologists commenting on incidental vascular findings. So I put another link to a paper one of my former residents, who's now a neuroimmunologist, neurorheumatologist, and myself put together to try to discourage overdiagnosing this condition if people are interested. Thank you all again. Unfortunately for this, I'm on service the next 2 weeks, so I won't be able to have Neuro Morning reports, but we have a whole library of them now. I think today's podcast that's coming out is a prior Neuro Morning report. So hopefully go through some of those and enjoy during the 2 Tuesday mornings off, and hope you'll be excited to volunteer to discuss a case in April when I'm back, because we would love to have more volunteers for discussion and more time for discussion, so we don't run over for the 10 minutes at the beginning, begging people to sign up. So thank you again, everyone. Have a nice Tuesday, and see you next time in a few weeks.
Bye-bye.
Bye, everyone.
Bye, everybody. Thank you.